what we've got now in day surgery is people thinking that a general anesthesia or general anesthetic is just quick and easy, and not really appreciating what they can do with spinal anesthesia now. I think people just need to sort of start questioning how they're actually working, and just working in different ways. People say, well, but I can't do a spinal and a GA. Well, why not? You need to look at the way you work and change your practice so that you can make it work.
Welcome. My name is Mike Nathanson. It's my pleasure to chair this session, this industry-sponsored session sponsored by Sintetica, for which we are very grateful. We thank them for putting together this very distinguished panel, which I'll come to in a minute, and for putting on this event and for providing the lunch. Just so that you are aware, this session is being filmed, like most of the sessions at the rest of the meeting, but I thought I ought to make that clear to you. It's a very my pleasure to welcome to this session on consent and choice and the impact of that for anaesthetists, particularly in day case anaesthesia. So the panel we have for you, who I'm going to introduce just to save time, because we only have an hour, is very expert on this topic. We've got some great people to give their opinions. Not only is it my privilege to chair the panel, it's also my responsibility to keep them in order. I'm not suggesting that the order in which they're sat near to me is in any way reflects which of them needs more keeping in order. I'll leave that for you to determine once we get going. So starting at the far end, and I should also add, just for clarity, that all the people here who have been invited are the great and good of anaesthesia and regional anaesthesia and our legal opinion, but they are here in their own right. Their views they're expressing are their own. They're not those of Sintetica or those of the organisations that they may or may not be associated with. So at the far end, Morné Warmruns, who I think now is the ex-president of the Regional Anaesthesia UK, so clearly his interest in regional anaesthesia is plain to everyone. Next is Dr. William Harrop-Griffiths, ex-president of the association, council member of the Royal College of Anaesthetists, and also a regional anaesthesia guru. Next along, Dr. David Bogard from my part of the world in Nottingham, who is well known for his views related to obstetric anaesthesia and spinal anaesthesia, and therefore obviously will also have much interest in the use of regional anaesthesia. It's a particular pleasure to welcome Lauren, who is our QC from Scotland. Lauren's has many claims to fame, but one of them being particularly relevant to this session is that she was an advocate in the landmark case, the Montgomery landmark case. And to have Lauren Sutherland here is a real coup, and we very much look forward to hearing her insights into the subject of consent for anaesthesia. Mary Stocker, president or ex-president at BADS now?
Still president.
Still president at BADS, the British Association of Day Surgery. And then last but not least, Simon Fletcher, who is a vice president of the College of Anaesthetists, hails from Norfolk and has its own views on anaesthesia. To kick off, the main purpose of this session is to get as much question and answers going as possible, a bit like a question time session. I'm David Dimbleby. These are the naughty politicians, and it's my job to sort them out. But the main purpose is to get you to submit questions. We do have 2 roving microphones that you can ask, or the association's events app that you will have been using in the other sessions already today has been enabled, so you can ask questions via that, and they'll come up on a screen here where I get an opportunity to enable them. So we're going to start off with 3 introductory statements just to set the scene about where we are at the moment with choice of anaesthesia and consenting patients who are undergoing day case surgery. First of all, I'm going to ask David Bogard to kick off and give us his views. Dave.
Thank you very much indeed, Mike, and thank you very much for inviting me. As you know, I do quite a lot of medico-legal work, but I'm going to try to avoid talking from that point of view and perhaps concentrate on my role as I was the first author of the consent guidelines from the Association of Anaesthetists, and that's been updated several times since I was involved. And I actually went to the association site and took a look at Annex 2 to the current consent guidelines, because they really have been expanded somewhat since I got involved with them. And Annex 2 asks a specific frequently asked question. Should I discuss a technique as a possible option, even if I don't feel I have the skills to use it, e.g. shoulder block for shoulder surgery? And the answer is quite a long one, and I'm not going to read it out, but it starts off, discussion of the treatment options should in general include alternative techniques, but it would be unreasonable to require inclusion of an exhaustive list of treatments that are not available to that patient. But it then goes on to say, having talked about spinal anaesthesia and caesarean section, it is accepted practice to offer regional anaesthesia for other procedures, e.g. shoulder surgery, but it is not universal to offer this as a preferred option in all centres. The Working Party accepts, that's the Working Party on Consent, that opinions as to the preference for and availability of such techniques vary and suggests that anaesthetists present and explain the technique that is their unit's standard practice while explaining that there are other techniques that are used elsewhere and that the patient may have heard of. And then advises that if the patient requests one of those other techniques and you can't provide it, you should send them to somebody who can provide it. So I'm going to leave it at that, if that's all right with you, Mike. And throw that up in the air and leave it sitting there, because that is the recommendation from the organisation who is hosting us today.
And that may be a ball that Lauren wants to immediately bat back at you, so I'm going to ask Lauren. Thank you very much.
Thank you. Thank you for asking me to come and speak to you today. What I've been asked to do, it would be a day to talk about Montgomery and the journey in Montgomery, but I've been asked to give a very brief summary of some of the salient points that you could take out of Montgomery. One of the issues that was a problem for me, certainly having taught consent for many years to doctors and dentists, was that a patient's right to information from the medical profession was really circumscribed by what doctors, as the professional body, thought that they should tell them. Following Montgomery, the Supreme Court has made it clear that patients are now widely recognised as persons holding rights rather than as passive recipients of the care of the medical profession. That comes with it responsibilities for the patient as well. The Supreme Court said that the social developments of today point away from a relationship between the doctor and patient based on medical paternalism. An important feature of patient autonomy or self-determination is freedom to decide what is done with their own bodies. Now, many of you may not know, I've probably read the GMC guidance more than any doctor I've met, but since 1995, the GMC has recognised the right of the patient to be fully involved in decisions about their care. They have issued since 1998 specific guidance on consent, and it is concerning that in 2018, it's taken us to this point in time to talk about it in detail. The GMC have always recognised a patient-focused test in relation to information disclosure. Surprisingly for me, when I looked into it, other jurisdictions who have a similar law base, Canada and Australia, have recognised a patient-focused test. 1992 in Australia and 1980s in Canada. Australia introduced a test that was said at the time to be the most patient-focused test on information disclosure in the common law jurisdictions. Now, obtaining a patient's consent to treatment is not simply a matter of law, and I think that's important, and that's what I taught the students. It's a matter of professional ethics. The theory behind it is that choice is meaningless unless it's based on relevant information and advice. The choice to be made in relation to a treatment option calls for a decision to be made by the patient on information known to the doctor, not to the patient. But there has always been a recognition that there's a distinction between diagnosis and treatment, which is within your province, and disclosure to enable a patient to make choice. The term informed consent that we all use so widely is derived from American jurisprudence and was actually designed to expand liability of doctors. And it has, in my view, led to a flawed interpretation of information disclosure in the UK, where all we do is focus on obtaining that consent. When we talk about patients' autonomy or self-determination, the focus should be on choice. Consent is the process thereafter. A patient should be able to make informed decisions on reasonable options available for them, and in that situation they give valid or real consent. You can't have informed and uninformed consent. And that went back to Sidaway, which was one of the main cases and is recognised throughout the other jurisdictions. So Montgomery, without going into any detail in it, essentially was a case about a patient's right to choose, the right to know about the options for delivery of her baby and the risk and benefits of each option, and to make a choice, her choice, for her baby and herself. The focus of the Supreme Court was not on anything other than ethical and the professional guidance issued by the GMC for doctors. This was not a test formulated by lawyers for doctors, as has been said many times in the press. The Supreme Court had the advantage of written and verbal submissions from the GMC in terms of what they wanted ethically from their doctors and consenting patients. They totally embraced the GMC guidance on consent. Therefore, it was not a retrospective decision as has been suggested. Essentially what they've tried to do is to update and make us all think about our practice. Now, it's not a matter of the Supreme Court forcing you to change your practice, but what Lady Hale said towards the end is that the decision is there. There are many doctors who are careful doctors who consent their patients well, but for those of you who don't, the decision in Montgomery is there to enable a patient to litigate. The trend in Canada and Australia was not a floodgate of litigation. The trend was better patient care, and that's what the focus of the team in Montgomery was. Thank you.
Thank you. Solomon, what do you tell your patients about the incentive for anaesthesia?
I think we'll come to that in a little bit more detail presently, but I just want to, just as a few introductory remarks, say, as Mike has alluded to, the panel before you is essentially consists of experts, medico-legal experts, experts in regional anaesthesia, experts in day case anaesthesia, and then there's me. And as those of you who know me know, I'm an expert in nothing, and I'm here as the non-PC grumpy old man. To put it another way, I prefer, though, to be here as the voice of reason in this, okay? The pragmatist. I have no issue with the GMC guidance on consent, and indeed it's entirely consistent with the Montgomery ruling, as Lauren has pointed out to you. But we need to remember, and I'm sorry about this, that the patients come to hospital for an operation, not an anaesthetic, okay? The anaesthetic is implicit in that, and that's where we are. And I think we'd far better concern ourselves with that process, making sure that that process that has been proposed to the patient is appropriate for them, because quite often it isn't, and that they are entirely fit or as fit as they can be for that process. So advocacy for the patient in that respect. When you actually talk to the patients, most of them expect to be asleep. That's just what they expect. It's a culturally British thing. And they're worried about waking up or not waking up and how much pain they're in at the end of it. That's all they're worried about. I don't feel we are at significant risk as a group if we don't offer every multitude of anaesthetic technique to achieve the same end. So I'll stop there.
Okay, thank you. Just before I ask the first question to a member of the panel, just to remind you, if you have any questions, either submit them through the app or please put up your hand and we'll get a roving microphone to you. But the first question I'm going to put to Mary is, given what you've heard so far, what do you think the impact of this should be on day case anaesthesia, where, as Simon said, patients are coming in expecting a very short stay in hospital and then to go home as soon as they can, paying for it?
I think for me it comes down to the right technique for this patient, for this procedure, in my hands, and in terms of the implication to day surgery, knowing that I need to get them mobilised and home within a couple of hours. And I agree with many of the things that Simon has said. I think what is really important is that for the patients, consent is vital, but it's informed consent. And as Lauren has just said, a lot of what we know, they don't know. A lot of the implications for the decisions we make, they may not know. So it's about that information. But I think for day surgery, what's even more important is that a lot of this needs to have happened before I see them 5 minutes before their anaesthetic. Because if they're going to have regional anaesthesia, we need to have made sure that they're on a list with a regional anaesthetist. Ideally, we want them to be on a list that's all regional so that the day surgery unit process can work more effectively. Similarly, if we're going to do spinal anaesthesia, it's actually more efficient if we do, as Robbie will tell you tomorrow afternoon, a whole list of spinal cases as opposed to interposing the two. I think now day surgery is not minority surgery, it's major surgery. You know, there's trusts up and down the country now doing hip replacements routinely as day cases. So it's important that if we are using these techniques, we're using them well. We can't be doing 4 mils of bupivacaine into a spinal anaesthetic and they're lying flat for 6 hours and they still expect them to get through their physio and go home. So we've got to use clever techniques with the newer short-acting anaesthetics if we're going to enable day case surgery to be effective. And all that's got to come into the decision and the discussion and the consent.
Any questions yet from the floor? So the gentleman at the back, would you just mind waiting for a microphone to come to you? Just keep your hand up, sir, just so the person with the microphone can get to you. And here we go. If you don't mind introducing yourself, that would be very helpful.
Hi, sorry, Richard Harris from Doncaster and Basketball. My recent concern, because of difficulties we've got, is that patients have been often pre-assessed just the afternoon before. I see them in the morning, and that's the first time anybody will have given them a leaflet or talked about anaesthetics, because the surgeons certainly don't, and they've seen them outpatients. And I just wondered what people's opinion was, whether this is an appropriate thing to be happening, because I personally don't.
Dr. Harriet Griffiths, you've been a clinical director. What do you think about that organisational problem?
Well, in the same way that the Leader of Opposition often tells a story in question time, I'm going to tell you a story of a patient who won't be identifiable from how I tell it, but somebody who made an inquiry of the Royal College of Anaesthetists. And this is an intelligent, assertive woman who was scheduled for a total hip replacement, who went through all the correct pre-assessment processes, with nurse-led pre-assessment, was assessed as being fit and well, came in on the morning of surgery, and the anaesthetist very reasonably took time to go and see the patient and started discussing the options between a spinal anaesthetic and a general anaesthetic. And she turned around and said, I haven't got the time to make this decision in the 5 minutes you're giving me. I want to read more about it. I want to ask you questions about it, but you're telling me I have to decide now. This is not right. And that isn't right at all. Because we're using the term informed consent. We shouldn't be using the term informed consent, because consent doesn't exist unless it's informed. And the process that you describe, where probably for reasons of efficiency and expediency, somebody is pre-assessed the day before and then brought through to anaesthesia, that is not ideal. And I think that one of the things we should try and do is allow the time, the information, the opportunity to discuss with patients the forms of anaesthesia that actually provides proper, if you wish, informed consent. That is a difficult situation. Now, it may be that that patient should be offered the opportunity, look, we can do you tomorrow, but there'll be a limited opportunity to provide you with the full information, or we can provide you with the full information, opportunity for discussion, and then do it at a later date. The situation you described, for me, is not really ideal for consent.
Mornay, do you agree with William's view that we should be doing this better?
Absolutely. If you look at the litigation, especially in ambulatory surgery, it is normally a lack of information, lack of communication, and procedural pain that is the most of the concerns. And a bit where Simon mentioned that culturally people expect to be asleep, but whose culture is that? Is that the anaesthetist culture? Is that the British public's culture? Have we instilled that culture? And have we maybe not given them the choices in the past? If the main reason, if the main things that the patient's worried about is not or waking up during the anaesthetic, or not waking up, or having pain after the surgery, I mean, those are three very good reasons to actually do regional anaesthesia. I am obviously extremely biased towards regional anaesthesia, but only because I believe in it. I once did about, I think, 35 consecutive anaesthetics and did a block on every single patient for something. So if you don't use it as a sole technique, there is analgesia involved as well. And if you have a patient that is slightly more informed, maybe Googled a few things, and they realized that actually after my breast surgery I developed chronic pain. After my breast surgery I developed metastatic cancer, and potentially regional anesthesia could have solved some of these problems. Are you then not, and you never gave the patient that option? Is this not opening up another can of worms? And this is why I do actually offer my patients, even the knee arthroscopy patients, I say, unless you want to stay away, you can, there is an option for you. And I think we do have to give those options to the patients, and especially when other implications are there, like chronic pain as well.
Thank you. We've got a question from Robbie Erskine. Can I put the microphone down for Robbie, if you don't mind introducing yourself?
Robbie Erskine from Derby. I've got a question, well, aimed at Simon and maybe Mornay. you've just demonstrated that we are very prejudiced, aren't we? Probably the reason a lot of patients expect a general is about that's good. We've always told them they're going to have a general. So that's probably our fault as anaesthetists, because we've influenced patients. At the same time, one is saying that that is always the case, and should we be convinced of something else? And that's part of the problem. So how do you get a balanced view? I mean, if I was a patient who'd never been exposed to a general anaesthetic, I'm going to put this to the panel, never had a general anaesthetic, I was coming in for an arthroscopy, chat with the surgeon, he says, oh, well, we tend to do these awake, but you can have a general anaesthetic if you like. That's one way of putting it. Depends on the angle. How could you, somebody on the panel, convince that patient of the benefits of having a general anaesthetic and giving proper informed consent? I'd be interested to hear that angle.
I'm going to direct that question to Mary. Mary, what do you think about a patient coming in with that discussion, please?
Thanks. I think it is always really difficult when a patient has something in their mind, and that's why it's essential within a pathway that we're clear to the patient from the beginning what the options are. And we get this all the time with day surgery. As soon as one person says, might be a bit sore, you'll probably need to stay in, you've lost the plot. So it's really important that those people who are talking about things upstream are giving what the options are and not prejudicing the patient one way or the other. And probably the best way to deal with it is to ensure that in all the surgical outpatient clinics there is proper anaesthetic literature so that we can say, this is the variety of options, please have a read about it, and there will be further opportunities to discuss it at preoperative assessment. If you feel you'd like to meet an anaesthetist at that stage, tell us, and it can be fine today. But the important thing is right up front to get the options out to them so that they get time to think about them.
Thank you. I know William wants to come in on this point.
Just bear in mind that I'm more than being a passionate regional anaesthetist. I'm a rabid regional anaesthetist. Patients do not come to me, or I think to any of us, asking for a general anaesthetic. Because if you explore what they want, is they want unawareness. Unawareness and general anaesthesia are not the same. And I, like Mornay, and like virtually any of us who practice regional anaesthesia of some sort, and yes, even spinal and epidural analgesia and anaesthesia is regional anaesthesia, can provide a patient with unawareness without giving a general. So let's get out of this thing, they're asking for a general. They're asking you to be unaware of their surroundings during the procedure. And I think we need to take more of that attitude because it gives us more flexibility to design an anaesthetic around their real wishes, not our immediate assumption about what their wishes are.
Thank you. Any questions? I have some video. 2 minutes, I'll just ask one video and then I'll go over. Simon, one of the questions we were being asked is, there are potential serious complications with general anaesthesia, of course. MH, sucks apnea, etc. Rare but complicated. So,
hen's teeth complications.
Informed consent.
Okay.
You discuss those with your patient?
No, of course not. It's nonsense. That's not what Montgomery said either. I think, that if we talk about risk and outcome, there is no discernible difference in risk or outcome between any regional or general technique. I'm sorry, but there isn't. Okay, so we can't use long-term outcomes. We might tell you might feel better in the first hour after procedure, but that's about the length and the breadth of it. I have to say I use a lot of combined techniques. I use regional anaesthesia an awful lot and axial anaesthesia an awful lot. But most of my practice is actually, well, other than critical care, is major joint surgery. And we have a pre-assessment process in Norwich where the patients are pre-assessed generically, so not generally by the person that's anaesthetising. And the biggest anxiety I have when patients come and see me is they've told me I've got to be awake. I don't want to be awake. I don't want any awareness. And I hear what Will's saying, but I walk around and I see anaesthesia without an airway going on a lot of operating theatres, which I find dangerous personally. And if we look at awareness, we look at whatever it was, the awareness national audit, the vast majority of the patients are said to be aware had never had a general anaesthetic. They'd been under regional anaesthesia with sedation. And they'd clearly taken everything that was told to them because they thought they were having a general anaesthetic. So let's get realistic and pragmatic about this. Yes, of course there's a place for regional anaesthesia, and as I said, I combine most of my anaesthesia has a form of regional and or axial and a general anaesthetic with it. And if the patient wishes to be awake, they can be awake. But if they're awake in my book. You have a regional anaesthetic technique and no sedation. And that's the way I play it.
Thank you, Simon. When you started the Ratska, I saw Lauren's eyebrows twitch. Yes. And I feel it's incumbent on me to come to Lauren next, because I think she may have a view that is different about the discussion and conversations. Do you, Lauren?
I got a feeling you were going to put me on the spot. Yeah, well, this obviously, my view is the view of a lawyer, not a doctor, but the GMC, and back again at the GMC, Montgomery, I think anaesthetists do have to consent their patients. It's a separate process from any procedure that the surgeon is doing or the other doctor. And I do think that it requires a separate consent from an anaesthetist who knows about the risks and benefits of the anaesthetic that they're offering and can apply it to that particular patient, which the surgeon can't do. I also think that the anaesthetist has a duty in law, but also a duty, an ethical duty to advise of, and the law says, material risks. Now, how do you work out what that is? You look at the incidence of the risk, but if the incidence is high, then you tell about it. If the incidence is low, but the consequences are severe, you tell about it. These are quite clearly set out in Montgomery and Rogers against Whittaker and in the GMC. You do not have to tell people about all sorts of weird and wonderful other possibilities. It's reasonable options for that patient. And the most important thing is the doctor does not decide what the reasonable option is for that patient, because consent to a process requires the patient to input into that, and there may be patient details such as the type of job they do, such as their own particular fears, that inputs into that decision that makes them prefer one option rather than the other. So the Montgomery decision is putting the onus on you to talk to your patients and find out what that patient's particular needs are, and then to use your expertise to assist them in making a decision about which procedure they want to have, not for you to tell them which one you expect them to have, which would slide into what lawyers talk and doctors as medical paternalism, which is a big no-no if you're going to end up in court, I'm afraid.
I can see some of the members of the panel twitching to come in. I'm already going to thank them on your behalf for being better behaved than question time. They haven't interrupted each other yet, and I hope they don't. But I can see several hands going up.
I think somebody else is controlling our microphones.
William was first, and then I'm going to come on.
I promise to be quiet after this. I've got a specific question for you, Lauren. We know that very, 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 very occasionally with spinal anaesthesia, the patient can suffer from permanent hearing loss. Incidence, let's call it 1 in 100,000. Let's call it 1 in 200. Let's call it 1 in a million. It doesn't matter. That is a material risk to any human being who has hearing already. Are you saying that your analysis is that we should say to every patient undergoing spinal anaesthesia that hearing loss, let's call it 1 in a million, you must mention it to them in order to be compliant with what is now considered to be case law within the United Kingdom?
Well, what the case law in the United Kingdom, you need to remember, is developing, because Montgomery's come out and everyone's still fighting about it and trying to find out what it means.
Right now,
and
yes or no, you should. I know you're not given to a yes or no answer, because your profession steers you away from that. Do you feel that legally I'm obliged to mention that deafness?
I personally do, because I think that but what you do is, to avoid the hysteria surrounding it, is that think about this in a practical sense. If the complication is a significant one that will change that person's life, then the law, as developed in Australia and Canada, which the Supreme Court say with a big pointer, the law now is, as found and developed in Rogers against Whittaker, says you have to say about it. But what you say is, this is a complication, but and you give them the risk, and it's very small, and I've never had that risk. But if that person then was the one person who had that anaesthetic and had that, they would say it was never mentioned to me, and then certainly I would think you could have a problem with overzealous, you may say, lawyers saying, well, we're going to sue you on that basis that this was a material risk that wasn't discussed. Now, it may be that the court would then say, well, actually, even if the patient had been told about that risk is so small, the patient would have gone ahead anyway, and the claim wouldn't succeed, but you'd still have the inconvenience. And I had one really interesting anaesthetic case where a woman was given a general anaesthetic, and someone noticed that, albeit there was a detailed written discussion about the anaesthetic, she hadn't actually physically just signed the form, and there was panic, and they immediately brought her out of the anaesthetic, where she had a cardiac arrest, ended up in ITU, and it was sent to me, and they're saying we don't know what to do with this case, because the position of the doctors is that they were trying to get consent. That's why they immediately brought her out of the anaesthetic. Now, that's just patently ridiculous. That's someone focusing on a form where there was documented evidence that there had been a discussion. But this is the kind of overreaction that I think's being produced. But if we step back to professional practice, the professional practice says you tell about material risk where the incidence is high or the consequences are severe to the patient, and they list things like paraplegia, major sensory loss. If the consequence is you have a sore finger for a week, then I wouldn't think that was material.
Okay, I do want to draw this back a little minute to Daycase, but because this point has been so well discussed so far, has been so discussed from different angles so far, I do want to bring out a couple more people who want to comment. First of all, David, and then Morne.
Oh, I've been desperate to get in here.
I can sense it.
Yes. I'm also sensing some disquiet on the part of the audience. So can I do a very quick 2-question survey? Please raise your hand if you give general anaesthetics. Thank you very much. Please, keep them up, keep them up, keep them up, keep them up. Please, now, keep your hand up if you warn your patient about the risk of malignant hyperpyrexia. Thank you. Right, so here we have an interesting conundrum. Malignant hyperpyrexia, for Lauren's benefit, is a very hazardous but extremely rare complication that can cause death. How do we get around it? Lauren has said, I think the correct interpretation of Montgomery is that we should warn patients of very rare but very significant risks. She's correct in that, I'm sure. The current GMC guidance, which is currently in draft form from their previous 2008 version, says much the same thing and is unlikely to change. What I do, this is just a practical workaround. I don't know whether it's acceptable legally. I think it's acceptable ethically. I say to patients at the end of my alerts about risks, there are a number of very rare risks with an incidence of less than 1 in 100,000, which can be very severe if they occur. Do you want to know about them? And if they then say that, yes, then I'll start to explain them. I'm not sure whether it's an acceptable thing to do, but I feel happy doing it that way.
Morne.
I think the level of regional anaesthesia expertise in hospitals across the country, and also in the same hospital from day to day, just varies so much at the moment. And this is one of RAUK's ambitions, is that we all have at least a level of regional anaesthesia competency. I think if you are having a shoulder replacement, then an interscalene block of sort should be provided. Neck or femur fractures, there should be some form of fascial iliac or femoral nerve block, something of that sort. And if in your hands you can't provide that practice, I think anaesthesia or anaesthetists should be able to recognise when regional anaesthesia will benefit their patients and call and ask for appropriate help. I think at least there should be, hopefully, one expert or competent person in that particular block in your hospital. And this is the only way how things are going to grow, and we're going to learn from that. The other problem is that in orthopedics is that orthopedic colleagues are not the most patient of colleagues, shall we say. Really? They, yes. So providing regional anaesthesia is often just seen as a waste of time. Can't spend the time in the anaesthetic room, and this is where, as in certain centres, where these things can be overlapped, and you can provide the regional anaesthesia preemptively. And not taking up surgical time, those are the sort of protocols we try and aim for. But this all comes down to informed consent from the beginning, giving the patient all the information and all the options. And I think at the moment we're not doing that because of our institutional and organisational problems.
Okay, so Morne, just pressing on your point about training, do you think that all anaesthetists doing day case lists should be trained in regional anaesthesia? Or perhaps not, because that's not the way I want to do it. To word it differently, should people who are doing day case anaesthesia and regional anaesthesia have specific training for regional anaesthesia for day case surgery, whether that's regional or spine?
Absolutely. Well, I would hope that all anaesthetists can do a spinal by now, but I think there are 5 basic blocks that every anaesthetist should be able to, and luckily we've got some of our Irish counterparts that has written an extremely good book on level 1 competency in regional anaesthesia. And I think a femoral nerve block, a popliteal block, and an interscalene block, those are the sort of things that you should be able to provide. I'm talking about hand surgery, hand trauma patients, shoulder patients, foot and ankle. These are the sort of basic things that I think every anaesthetist should be competent in.
Simon, whilst I know you're not here specifically representing the college's views, you will have an insight into this from your college work. Has the college missed a trick in not highlighting to a great enough extent training in regional anaesthesia as an essential skill?
Regional anaesthesia is a central skill for training. It's in the curriculum and you're expected to do it. I think we've been not so specific about a list of competencies at the end of it. I mean,
I think that's what I'm getting at, is more specific.
I find a needle in the back works for most things below the waist, I have to say. It's quite effective. And actually it was very effective for knee replacements before we weren't allowed to do it anymore. And whatever else we do for them is ineffective. Upper limb surgery, Maureen knows what I do. I've got 1 block in the upper limb. It's called the perivascular supraclavicular block, using the paresthesia technique. It works well every time, takes 2 minutes, takes 5 minutes to work if it's going to work. And wait for it, there's no increased complication by getting an ultrasound machine out and doing it. So it's and you can do shoulder surgery on it if you put enough volume in. But I mean, I'm a dinosaur. I'm out of here really. I do think it's important that the younger generation can do this. I want to talk a little bit just about the consent issue. I mean, if we're going to consent them and tell them about deafness, surely we should tell them about the danger of being run over by a truck on the way there, because it's far greater than deafness. And it's all part of the procedure. I mean, we're going to get out of hand here, I think. We need to be sensible and pragmatic. Of course, an anaesthetist should give consent. I'm never suggesting that a surgeon takes consent for us. We all see patients and tell them what we're going to do, and we offer them options. But and actually, everyone should have literature, and perhaps the literature that's sent out should have these complications in them. And if they want to discuss them, they discuss them.
Hello. Hi, I'm Kim Ruston. I'm a consultant anaesthetist from Rotherham, but also a regional anaesthetist and day surgery. It's a great panel. There's lots of questions I keep coming up. What I'd like to do, focus in to Lauren. Sorry, it's just, we talk about the pathway and whether we should give information before. Richard mentioned that earlier. If we give it written down in a leaflet a couple of days before or for however long, is that enough? Because, I mean, the college produces lots of leaflets. We, within our pre-op assessment, give out the you and your anaesthetic leaflet, and if they're going to, might be, where if a spinal might be indicated, we give the spinal one. Is that enough information for them, or do we have to sit down as an anaesthetist and go through it detail by detail? Sorry.
Leaflets, information leaflets are good, are recognised as good. I think the GMC recognise that as good as well. And patients obviously Google things now, and they're encouraged to, and the Supreme Court suggested that they do require to do some investigation on their own. It's not enough to leave it to the doctor. But the problem with a leaflet is that will be a generalised information leaflet, and it's not particularised to the patient. And the test now is a twofold test, which talks about the reasonable patient. But if there's information that you know specific to that patient, there's another duty incumbent upon you to look at the risks relative to that patient. So early discussion is good because it gives people time to think and then think of questions and bring questions. But you would have to pick up, if you gave a leaflet which quoted a percentage complication risk of X for the generality of the population, and then this patient had a different complication rate because of something particular to them, their airway or whatever, then I think as far as the law is concerned, I think the GMC say as well, you would need to pick that up with the patient and check. There's no duty in law to ensure that the patient understands everything that's said to them. You just have a duty to take reasonable care to disseminate the information that's needed to make the choice. So leaflets are a good thing. And if you look at the private sector in plastics, they've been doing leaflets for years because they're very aware of being sued. sometimes the nature of the patient, but they cover themselves with the leaflets, specific consent forms, and some units even have a computerised checklist which they ask the patient questions to check if the patient's actually understood. Now, they're in a private sector, they have more time to understand that, but if you've got a leaflet, I think it's good, because if it goes to litigation, you have the leaflet there, but I would also particularise it to the patient.
Do we need to sign then for that consent?
I'm going to come on to that. So actually, thank you, that's a good point. I was going to come on to it. David, we've heard a lot already in this session about consent. We've heard a lot about offering the choice and what choice we offer. Has the time come where we should now mandate a written record?
Well, I think most of us keep a written record of the consent process that we have gone through with the patient. The majority of the notes that I see, whether in my clinical or medico-legal practice, have listed the basic features of risk and benefit that have been discussed with the patient, often on the anaesthetic chart. And the anaesthetist may well have ticked a box and then written down what risks is explained next to that. What you're asking about, I think, is consent signed by the patient. And you will note the AAGBI guidance, in which I had some considerable input in the early days, has steered away from recommending signed consent from the patient. And I'm sure Lauren will confirm that the signature of a patient doesn't add significantly to the legal value of a consent form, other than to say you haven't just made it up and written it down. And if it was suspected the doctor had just made up the stuff he'd written down and hadn't told the patient about it, they would be facing a lot more than consequences in the civil courts. So I would still not push for written consent, although there are, of course, some areas of medical practice where you have a legal requirement for written consent, including in vitro fertilisation procedures, for example.
It's the only one, isn't it?
Thank you. The gentleman just on the second, you can just wait for the microphone to come to you. Just here.
In the meantime, if you give the information leaflet and the patient ticks and agrees that they've read the leaflet, and then you can put the minutiae detail in that leaflet, does that then save you from actually having to go through all the details again? Because when I do interscaling consent, I talk about motor block, I talk about failure, I talk about phrenic nerve, and I talk about Horner syndrome. I don't always talk about local anesthetic toxicity. I don't talk about death. I don't talk about very, very rare Harlequin syndromes and things like that. So, you know, but if it's mentioned in the leaflet, is that good enough?
Is that a question you want to put, or just you want to leave hanging?
Well, I want to benefit. You know, you're not going to get free advice often. Not from a lawyer, anyway.
No, are you okay to give an answer to that before we move on to the next question? Sorry to put you on the spot again.
So the leaflet does not allow you to walk away from any discussion, because people have varying abilities to read and understand leaflets, and it depends on the leaflet and how it's written and where the language of the leaflet, if the patient can actually understand it. So if there's a brief discussion with the leaflets being handed out saying, now I want you to go home and read that, and if there's anything you don't understand in that leaflet, come back, we're going to have another discussion and flag it up to me. That normally for the court, as far as the courts are concerned, is enough. But you should, when I teach the dental medical students, I say, make a note. That's not the same as anaesthetic, obviously, but if you're reviewing a patient, make a note, because in 3 or 4 years' time it may come back to you and you won't remember a single thing about this consultation or the patient. The patient will say, I remember it like it was yesterday because it was the most major event in my life. And you're in a very vulnerable position. It's not defensive medicine, it's good practice, because then it's there for other people. So if there's a medical note discussed X, Y, Z with patient, full information and risks, and leaflets handed out, that would be a very difficult case for the patient to say I didn't get anything and to successfully litigate. There is a bit of a flurry of consent. Everything's a consent case just now, but lawyers get a bit overexcited. And the stuff that's been litigated that's not properly consent, but everyone just thinks, oh, this is the thing to do now, we'll just suit everything in consent. It'll settle down, and then people's practice will change. Lawyers for years, when they speak to their clients and give them advice, follow it up. We spoke today, and this is the advice I gave you, X, Y, Z. And when the clients try to sue them, it's all in the record. Harder for anaesthetists because you're coming in at a different place, but a little note is always there to help you at a later stage, and that is for litigation.
Thank you. Gentleman here.
Stefan Oaks from Blackburn. Are we not doing a bit of a merry dance here between ideal and reality, as one question at the beginning came already as well? I just don't have the time. I simply don't have the time to discuss all these nice things with my patients. They might or might not have got a leaflet, but the reality is they don't get seen before. The surgeon tells them they're going to sleep and that they get sorted. And if they have questions, I have 5-10 minutes, maybe, to tell them that, and I start early already. There is this ideal, and it's totally correct, that the patient should decide all this with us. But we are not set up, we're not funded, we can't.
So
And
Mary,
apart from that, I quite like sometimes to have a solicitor with me when I'm talking to them.
thank you. So Mary, whilst pressures our colleagues described can occur on any list, perhaps day case list is the one that springs to mind because of the volume of work and the time sensitivity. So what would you like to say back?
I think it's a really valid point, and for us to be able to ensure that patients have the right information to make the right choice, things have to happen upstream. Because if you've got 8 patients on a morning urology list, you haven't got the luxury of 10 minutes. Speaking as a jobbing anaesthetist in Devon, what we do is our nurses give out a preparation for surgery booklet, but within it we've got all the anaesthetic leaflets. So we've got the information about general anaesthetic, regional anaesthetic and spinal anaesthetic, and we document on the pre-assessment that they've been given this. So at least we have documentation that they've been given the information. And to a certain extent, I think we have to give patients some responsibility to take responsibility for their own health and to read the information that we provide them with and then come to us with specific questions, as opposed to us being expected to do everything, because it's not realistic.
So just to expand on that a little bit, you are doing your day case list in Devon, describing the real world situation, and you go and talk to a patient about having a spinal anaesthetic. Is this a discussion which you find is difficult or tricky? Do you find the patients receptive? Is the culture there, both in the hospital and in your population, you think, to get it? Or is it still a battle for you?
I think it depends on the procedure. So for our hip replacement patients, the expectation is that they will have a spinal anaesthetic because that's been discussed all the way through the pathway. The other group of patients that I personally use spinals for routinely in day surgery is the TURPs. It may not have been what they've come in expecting, but to be fair, they're usually fairly compliant elderly gentlemen who are happy to go with whatever.
And for 50% of the room, it could be us, so we're aware of it.
Soon for some of us.
We'll book you in. So I think it does depend a little bit on patient population and on expectation. And then there's other patients for whom it becomes clear that they're, very clear early on, I want a general anaesthetic or I want a regional anaesthetic, and these are the reasons. And at that point it is patient choice if there isn't a very clinical reason to go one way or the other. But generally, no, certain population groups are well prepared with what the kind of outcomes are likely to be, but for others, it's a bit of a surprise.
William, do you think the culture exists within the providers to make this change, to give people a wider choice than we've historically done? Or do you think it's still down to, as you said, the rabid regionalists like yourself who are pushing the boundaries?
There's one good thing about the lawyers, is they are pulling us towards giving the patient real choice, a real consent process, real information. It's down to the individual hospitals to decide whether we actually exploit that choice, whether we make that choice real, the point that you very well made, and the gentleman behind you, by giving us more time to talk to patients, by creating a system and a process whereby the patients are given more information in advance and have access to people that they can ask questions. That's the choice. Are we going to expand that? Are we going to spend money on that in order to pursue the ideal that the lawyers set for us in their judgments? Or are we going to just go for efficiency? We can just go for efficiency, but we must be absolutely mindful that you place the people who work for the hospital at risk by doing so. You are also taking away the absolute right of a patient to decide based on the full information. I would love to see us go in a direction where we pursue the ideals that we are being set, but we must bear in mind that we are limited in our cash reserves. But any choice made must be a conscious choice, that we are limiting patient choice. We are doing so in order to maximise efficiency. Those are uncomfortable questions to ask of our masters, but ultimately they are the questions that we will need to ask.
Thank you. I'm going. There's a ripple of applause even.
No, it wasn't.
I'm going to go along the rest of the panel for any closing views they want to express, and then if William wants, give him the last word at the end of that. So, Mornay.
I think 2 points I'd like to make. One is, in our day surgery, we don't seem to have criteria about what's acceptable and unacceptable anymore. You know, there's ASA 3 and 4 patients, BMIs in the 50s, sleep apnea, heart failure, all sorts of things are getting through day surgery these days. And the comorbidities are increasing and the age is increasing, especially the elderly urology patients. And this is the population group where I find a spinal anesthesia particularly helpful. The second point is that we still have this brushing all spinal anesthetics with the same brush. I think part of the organisers of this symposium, I think one of the main messages would be that they are not all the same spinal anaesthetics. The side effects of a bupivacaine compared to a prilocaine compared to a chloroprocaine spinal anaesthetic, the side effects and the advantages are different for each of those drugs. And I think we should pick the right drug for the right patient, for the right procedure. I know it sounds a bit like a sales pitch, but often these drugs are not considered, and they may not be available everywhere yet, but I think this is something that we should aim towards, because I think especially for post-operative cognitive dysfunction in that urology population, I think short-acting spinal seems to be the way forward.
David.
Yes, I can make 2 points, really. First of all, on the grounds that doctors don't always believe what lawyers tell them, and because of William's fairly impassioned comments just now, I really must stress that Lauren is absolutely right. Lawyers are not telling doctors how to go about a consent process. Lawyers and judges are taking advice from the medical profession, interpreting it absolutely correctly to my mind, and telling us what we've been doing wrong for quite a long time. We are not led by lawyers on this, we're led by doctors, and quite rightly. The second thing is the topic of this discussion might a few days ago have been seen to be a minority interest, but it's not. We've just seen the latest unveiling of the new plan for the NHS, and that is one of the key features of that is an increase in day surgery, an increase in rapid turnover surgery, sending patients home the same day. These are going to be questions that we have to, even those of us who don't do day case on a regular basis, are going to have to address increasingly frequently as if this plan comes into fruition, and who knows whether it will. And the question of whether we do regional blocks on patients that are going home the same day is going to be something we're all going to have to answer. And I guess the final thing I was going to say is there's a difference between in my head, difference between shoulder blocks and spinals. I think everybody in this room should be able to do spinals. I don't think everybody in this room should be able to do shoulder blocks, because for example, I never anaesthetize anybody for anything in the arm or any trauma patient at all. But a spinal seems to me to be a basic requirement of the generalist anaesthetist.
Thank you. Lauren.
Picking up on that point, what I would say about Montgomery, as the case came to me and I looked at it, I recognised from the outset that it wasn't for lawyers to tell doctors how to do their job, and we had very limited understanding of the pressures, albeit I have a daughter who is a registrar. We don't have an understanding of the pressures that you work under. That is why I went straight to the GMC, and I started with the GMC guidance. I read all of the guidance, and the argument was written and formulated with the GMC guidance at its core. If the professional guidance in the GMC had not existed, Montgomery would not have gone forward. There was a very interesting quote in one of the bioethicist books which said, you know, a patient is not a person with rights and family decision-making powers, and then goes into hospital and is given a pair of pyjamas and loses all of that, and then restores to a person with rights when they leave. And that person is still the same person. And one of the Supreme Court judges made it clear that, in his view, it was about dignity and respect for your patients. And that was the fundamental thing about choice, that it was about your patient. And I understand, and they did understand, that this was going to be a difficult thing for the medical profession to have to deal with against the backdrop of your very difficult and busy lives. But they felt that that was something that had to be done. Because if you think about it, before Montgomery, a person was only entitled to know what doctors decided they would know about risks, not what they wanted to know. And if you were a little educated, you knew nothing about medicine, you would just get this filtered view. If you were intelligent or you had relatives who were doctors, you would ask the doctor questions, and that patient, the doctor would have to answer truthfully, and that patient was entitled to information that the poorly educated person could never access. And that cannot be right in any sense of the words. So my feeling is that we all want to improve and inspire, and we can perhaps try and do our best to move step by step towards a culture where we try as best we can to give people information. These people don't then come and sue you, and you deliver better patient care.
Thank you. Mary, any closing thoughts?
Well, I'm in danger of agreeing with two of my panellists. I'm delighted to hear that the...
That will never happen on the question time.
Delighted to hear that the penny has finally dropped, and hearing from Marnie that people now realise day surgery is for the old, the fat, the unfit, and the patients having long surgery. So that's great. But also the issue about who can do a shoulder block. I wouldn't offer a patient a shoulder block in my hands, because they'd be much better having a shoulder block in Kim or Robbie's hands. I do shoulder surgery once every blue moon. So again, it goes back to the organisation. We have a duty to give a gold star service to the patients, but also a gold star service to the NHS to be efficient, to be prudent with our resources. So we have to get things organised in advance so that we know this patient has got this offer, but they come on a day surgery regional anaesthetic list or a day surgery spinal anaesthetic list, so that the patients get given the choice, but also we can keep the service running efficiently, and we've got the right patients in the right time for the right procedure.
Thank you. Simon?
Very quickly, because I know we're over time. Okay, so I agree there is no place in modern world for hubris, for medical paternalism, but I don't think we can be held responsible for patient passivity, if you know what I mean. In other words, if you provide them the information, it's all there and they don't take it up, it's not your fault. And of course we need to facilitate people who don't have the educational background to understand what's going on. One point. Another point is, I want to use the word framing in the follow-up. Mornay's just framed beautifully regional anaesthesia is an advocacy for it. And there is no evidence to justify what he said, that regional anaesthesia might be helpful, but it's no better for the patient. The outcomes are no different. And while I'm not an expert on much, I do know quite a lot about post-operative cognitive dysfunction doing critical care, and it's actually physiological stress that causes it. It's nothing to do with the anaesthetic. It's probably a lot to do with the benzodiazepines you give them while you're sedating them, actually, if you want to be truthful now. But it certainly isn't a lot to do with isoflurane, which is not a GABA agonist. But there we are. That's my view there.
I can't imagine how we got to this point. That we seem to have the final word given to William Harrison.
Well, okay, 1 minute, and that's all, and then you can go. I think we're all agreed it's the patient's choice, the form of anaesthesia, and that our duty is to give them the reasonable and feasible options and discuss it with them. That we can advise them on the basis of the statistics, our own personal experience, perhaps or not, whether we can do the procedure. That seems to be a bit of a grey area. But I think we're all agreed that we cannot compress a reasonable consent process into 5 to 10 minutes. And that is a really, really serious area that we need to work on. We need to persuade hospitals to invest in patient autonomy by creating processes and allowing time for the proper consent process to anaesthesia to actually happen. But the fascinating thing for me for the last hour or so has been this area of the vanishingly rare. and the fact that we seem to be taking a big risk with our health, our lives, and our careers every time we pick up a syringe because of uncertainty about that area. I think there is a responsibility to the people who lead this profession, to the Association of Anaesthetists, and to the college to help us. I think they need to sharpen up their guidance on consent.
That'll be you and me, Will, then. That'll be you and me.
That's me, yes, that's us. I will, it's in full flow, Simon. They need to offer a written consent form for those who might wish to choose it for some patients. They need to provide a more comprehensive list of complications with recognised incidences from which you can draw for particular patients. But perhaps most importantly, and I don't learn much from David Bogart, but I've learned something today, a form of words that we can use, recommended by the leadership of our profession for that very rare occurrence. There are some things that are less than 1 in 100,000 which may have significant risk. Would you like to know about them? So you can put down on paper that you've used that to provide your patient with reasonable guidance and yourself and your hospital with some sort of protection.
Thank you very much. On your behalf, as well as thanking the panel, I would also like to thank everyone who's contributed. It's been fantastic. We've had lots of questions submitted by the app. We've gone through many of them, and we've had lots of questions to the floor. You made it a very productive session. I hope you've enjoyed it. I thank our sponsors again for providing the panel, providing the lunch, and providing the facilities. And please enjoy the rest of the meeting. Thank you very much.